Hello, everyone. I'm Dr. Patty Pellikka, Editor-in-Chief of Journal of the American Society of Echocardiography. Welcome to Author Spotlight for the month of February. Today, I'm joined by Dr. Kevin Harris. Kevin is a cardiologist at Minneapolis Heart Institute, Abbott Northwestern Hospital in Minneapolis. And he has published an interesting paper, Rate of Ascending Aortic Enlargement in a Large Echocardiographic Cohort, Associated Risk Factors and Adverse Aortic Events. Welcome, Kevin.
Thanks, Patty.
So this is a really nice study because it always comes up how often we need to follow these patients with dilated aortas on their transthoracic echo. Tell us a little bit about how you designed the study in your population.
Well, like you said, I mean, it's a common problem for any of us that read echoes or take care of patients. And, you know, we always struggle, and I get a lot of calls from primary care docs. How often should we repeat the echo? And the impetus for the study was there was a meta-analysis that was published that said the growth rate is 0.6 millimeters per year. And, you know, that just seemed far greater than anything I've seen in my own clinical practice, having taken care of a lot of these patients. So Steve Bradley, who's one of my colleagues and is connected to we have a large data warehouse at Alina. You know, we were talking about that paper, and we should look at this ourselves. And so he had access to this data, basically pulling the results of our echoes in our large health system over almost 11 years, looking at the patients with dilated aortas, defined really as 4 centimeters or greater. And so we ended up with over 3,600 patients that had a baseline echo and then had a follow-up echo within 5 years within our system.
Yeah, really excellent data. What did you find?
So not unexpectedly, and actually fairly consistent with some of the older data, the growth rate overall for the tri-leaflet valves was 0.08 millimeters per year. So that computes to about 0.1 millimeter per year. For those patients that had a bicuspid valve, it was 0.4 millimeters per year. So a significantly greater growth rate in that population.
That's sort of in line with what I think we anecdotally see clinically here. They don't tend to grow that fast, but about 0.01 centimeter per year for most patients.
The vast majority of patients are not growing very fast. And the growth rate is a little bit greater in those with the bicuspid valve. There was a small subset that actually went on to have a dissection, and the growth rate in those and that was just 6 patients, but the growth rate in those patients was actually 0.9 millimeters per year, so 0.98 millimeters per year. So, a higher growth rate, which is worth, further study in that particular population.
Yeah, and you noted that the growth did not seem to be impacted by the baseline size of the aorta, right?
Yeah, I thought that was interesting because, it's natural for us to follow the patients closer that are, larger aortas. So that was interesting. I'm not sure I totally understand that. And that's a little bit at odds with some of the prior data.
You also looked at the impact of aortic stenosis and hypertension.
Yeah, and those did not have any discernible impact on the growth rate.
Some of your patients had a prosthetic valve.
And the growth rate in the patients with the prosthetic valves was actually fairly similar to the regular, the patients with the tri-leaflet valves. The only real outlier was the bicuspid valve in this study.
So guidelines talk about following these patients every 6 to 12 months with imaging. Do you think that that's too often, or have you changed your practice?
Yeah, no, I think it's an excellent question, and I I did happen to see the editorial that was written about this paper, which I think is really excellent and has a really nice table detailing some of the guideline recommendations. So the ACC/AHA guidelines, which are available, as you said, say follow-up echo in 6 to 12 months after your first diagnosis. You could space that out a little bit if it's stable up to 24 months. And I think that's definitely appropriate in the patients that are towards the smaller end of the spectrum, the older patients, that incidentally are now discovered for the first time to have a 4.1 centimeter aorta, which actually may not be too abnormal for their age and body size. But the newer European guidelines, which were just published as this article was in review, actually have a little bit longer follow-up interval up to like 3 years for stable patients. So I think it will impact our practice a little bit as far as our recommendations to the primary care docs. I mean, certainly those with smaller aortas, I think can be followed. That have trileaflet valves certainly can be followed at longer time intervals, and certainly bicuspid valves, the larger aortas, I think they deserve closer follow-up.
Yes. So in summary, you found a mean annual growth rate for ascending aortic aneurysm of about 0.1 millimeter per year for the standard trileaflet, the common trileaflet valve. And in the subset with bicuspid valves, it was about 4 times that, 0.4 millimeters per year.
Yeah, I think that's a nice way of summarizing it.
What are the next steps?
Well, we're working to try to work this into our echo report to try to give the primary care docs a little bit more guidance, as far as what to do when they discover this. And, of course, there's members of our group that are like, well, dilated aorta, that's an easy follow-up. We could, that is not that important, but for that individual patient, it's very important, right? And I think you see that patient back and their aorta is, whatever it is, 4-5. I see a lot of 4-5 aortas. You're like controlling their, you're talking about their risk, you're working on their blood pressure, tobacco, avoidance, fluoroquinolones, talk about isometric exercise, et cetera. So I think it is valuable. So to me, I always try to weigh the benefit of the follow-up and getting the patient back in front of their clinician versus, kind of saving the healthcare system and the patient and everyone time by spacing it out. So I think maybe this will lead to a little bit more nuanced recommendations from our group as far as when the follow-up is necessary.
Great. Thank you. Thanks for visiting with me, Kevin, and thanks for publishing in JASE.
Yeah, thanks very much, Patty. I appreciate it.
And then I'd like to refer our readers to the excellent editorial that was written by Doctors Anita and Michelle Kelsey in the same issue. Thank you all.